What's up, future respiratory therapist? I got a question here coming to me from Fred. He asked if I could do a breakdown of adaptive support ventilation. This is the ASV mode on the Hamilton ventilator. So what I want to do is talk to you about a couple of concepts related to ASV and other modes of mechanical ventilation, and then talk about what we set in ASV, and then what the vent does during this mode. And then I'm probably going to get on my soapbox based off of an ASV video that I watched promoting the mode of ASV. So we'll kind of go in that order just so you kind of know what's going on. At any point in time, drop a comment below, give me a like or a dislike, I don't care, whichever one you prefer. And subscribe to my channel if you haven't already, okay? So here we go. Adaptive support ventilation is a relatively new mode of mechanical ventilation here in the United States. Now, it's actually been available since 1998, okay? But it didn't make its way to the States until about 2007. So we're only looking at a mode of mechanical ventilation that's been around and readily available in the States for about a decade. Okay, so if you've never heard of this mode, it's not surprising to me, okay? If you work in an area that uses this mode all the time and you have extensive experience with this mode, I would love for you to tell me about it down in the comments, okay? I'd like to know where you're using it, and I'd like to know your thoughts on it as a mode of mechanical ventilation. The pros, the cons, just all the ins and outs of it that you see on a daily basis working with it, okay? Because I've talked to multiple people about this mode, and I don't personally know a respiratory therapist that works with it on a regular basis, okay? So I'd love to learn from you guys in helping me what you actually see real life in the clinical setting with this mode, okay? So the first thing to understand is when it comes to this mode is that we're talking about technology that is evolving. And we're talking about open loop versus closed loop. Okay, when I say that, I'm saying open loop ventilation versus closed loop ventilation. Okay, so here's the difference in open loop versus closed loop ventilation. Traditionally, if you primarily work with assist control, pressure control, SIMV, pressure control, SIMV, pressure support ventilation, what you've been working with is an open loop form of mechanical ventilation, which means you tell the ventilator what to do and the vent does it. Nothing coming back to the vent alters what the vent is going to do on the next breath. Okay? That's open loop. The vent does what you tell it to do. Okay? Now when you get to closed loop ventilation, what you're talking about is a loop, a continuous loop of input that's going to the patient. You told the vent to do this. When the vent did this, this data came back to the vent. The vent, the artificial intelligence of the ventilator, interpreted that data and it dictated what it does next. Okay? So I told you open loop, you're talking about VCAC, VCSIMV, PCAC, PCSIMV, even APRV, bilevel, pressure support ventilation. Those are all open loop forms of mechanical ventilation. They do not change from the input that you tell them to do. Okay? Closed loop would be, examples would be adaptive support ventilation, proportional assist ventilation being PAV, NAVA, okay? Those are three of the more common. You could even argue that PRVC is a closed loop form of mechanical ventilation, and maybe the first closed loop form of mechanical ventilation, where the vent gives a breath. If the tidal volume comes back not to where it's supposed to be or greater than where it's supposed to be, the vent changes the pressure given on the next breath. That's a closed loop form of mechanical ventilation. Okay, so that's the first thing to understand is what type of technology are we working with here. Okay, now from there you need to understand in ASV what do we set, and there's only very few settings. Okay, so you've got I'm just going to put it right here, settings. Okay, and so what we do is we set the minute volume. Okay, so I'm just going to say MVE. Okay, so this is the minute volume set. Now we actually set this in a percentage. And so you tell the vent to ensure, and they said you typically start this out at 100%. Okay, so ensure 100% of the set minute volume that I'm telling you to ensure. Okay, so you're telling the machine up front to deliver a set minute volume, or to ensure that this minute volume is achieved. Okay, not a tidal volume, not a respiratory rate, but a minute volume. Okay, you also need to tell the ventilator your patient's ideal body weight and sex. Now, this isn't in conjunction with minute volume, but this will tell the ventilator the range to adjust your tidal volume. Okay, we use ideal body weight and sex to establish ideal tidal volumes. Okay, and so the ventilator is going to, with this information, calculate and determine a tidal volume appropriate for this patient. Now, the other thing you're going to set is FiO2. You're going to set PEEP, and you're going to set a max pressure. Okay, so max pressure. This is the pressure that will not be exceeded. Okay, and this will make more sense here in just a second. Okay, now after you tell the vent to do these things, okay, then it is going to ventilate the patient based off of a closed loop system, which means it's going to evaluate what happens. Okay, it is then going to establish an ideal respiratory rate, an ideal tidal volume, an ideal I to E ratio. Okay, and it's going to use those to then determine how it ventilates the patient, if it has to ventilate at all. Okay, now my understanding of this is that once this is established, then if the patient is spontaneously breathing above this ideal respiratory rate meeting this minute ventilation, then the vent will allow the patient to breathe spontaneously in pressure support mode. Okay, and it'll adjust the pressure support to establish an ideal tidal volume in conjunction to establishing that, maintaining that minimal minute ventilation. Now, if the patient drops below the high end of that respiratory rate, but does not drop below the low end of the respiratory rate that the vent established, okay, then the vent will support the patient with pressure control SI and V breaths. Okay, so it's going to come in, and again, based off of the I to E ratio that it determined, it will determine the appropriate peak inspiratory pressure, the appropriate I time to get the appropriate tidal volume to help support and maintain that mechanical, that minimum minute ventilation that has been set. If the patient is not breathing at all, the vent will go into full mechanical ventilation mode and mechanically ventilate this patient in pressure control mode of mechanical ventilation. Okay, that's how it works. Now, you want, like, thinking to yourself, like, well, how does it establish respiratory rate, tidal volume, I to E, a PIP, I time? How does it establish all of that? Well, man, that's some deep shit. That's deep engineering logarithms ingrained into the mechanical ventilator that you can find with a quick ASV search through Google Scholar. You'll find lots of research out there on this mode that will actually break down and talk about those algorithms that include resistance, compliance, elasticity, all that stuff. Okay? I'm not smart enough to understand it, to be honest with you. Okay? And I don't really care as long as I understand that my patient is being adequately ventilated. Okay? That's my whole focus. Okay? Now, I told you that I was probably going to get on my soapbox at the end of this, and here I go. All right? I wanted to look up to see what the marketing material looked like for adaptive support ventilation through Hamilton. So what type of videos do they have out there educating, you know, the respiratory therapists and nurses and doctors on adaptive support ventilation? And their primary video that pulls up is a video that consists of, it's either 3, 4, or 5 physicians, okay? And these physicians are standing at the bedside and they're talking about this mode of mechanical ventilation. They're talking about how the patients are more synchronous, which is true, Okay, anytime you have a ventilator who doesn't force itself on the patient and allows the patient to have some control, you're obviously going to have a greater level of synchrony, okay, which makes perfect sense. I tell you guys all the time, right? Make the ventilator breathe like the patient, not the patient breathe like the ventilator. These modes, these closed loop modes, they work to ensure that the vent is meeting the patient's needs, not the other way around. Okay, you put somebody in assist control and say, this is how you're going to breathe, like it or not. You're going to have breath stacking, air trapping, bucking the vent. You're going to have all kinds of asynchrony present, right? So these modes do, I believe, these closed loop modes of mechanical ventilation, for the most part, I do believe they aid in creating ventilator synchrony with the patient. Okay, but the thing I had a problem with was this. They were talking about that this is a mode that you can put in, you can put on the patient from intubation to extubation. I don't have a problem with that. Okay, that makes sense actually, because the mode will automatically adjust from full mechanical support to minimal patient support. Okay, so that makes sense, and I can see that being an advantage to it. I can see you not having to go in and say, oh, okay, now we're going to start weaning the patient, so let's go from AC to pressure support ventilation. Okay, I get it. Or let's go to PAV now. You have to go in and actually change it over. Okay, so I buy that. It adapts to the patient from full support to minimal support. Okay, I get that. What I do have a problem with is that the words out of their mouth was, this mode allows me to spend less time at the bedside. Okay, doc. So this mode allows you to spend 3 minutes at the bedside instead of 4? Like, really, come on. Like, I've been doing this for 20 years. I know that at the end of the day, every respiratory therapist and every nurse alive spends more time at the bedside than the physician does. Substantially. I'm not saying there's not one or two docs out there that don't. That's not what I'm saying. I'm not saying all. I'm saying overall most docs spend a very limited amount of time in the rooms anyways. So I don't see an advantage of this mode being that they were allowed to spend less time in the rooms with their patients. Okay. Now, if it was a respiratory therapist saying that, I would buy it. But then I would challenge you on this. Is that what we want? Is that what we need in 2019 going into 2020? Respiratory therapy, critical care medicine? Do we need modes of mechanical ventilation that allow us to spend less times with our patients? And I would argue this. A closed loop mode of mechanical ventilation where the vent is making decisions and changing things automatically and on its own in response to output from the patient. I would argue that those vent modes would need more monitoring, or at the very least, the exact same amount of monitoring as our open loop forms of mechanical ventilation. So I'm not buying the whole you get to spend less time at the bedside. As a matter of fact, I don't even think that's a good thing. We got into this and we do this to take care of sick people. We didn't do it to take care of a bunch of sick people. So everybody goes on ASV. Now you can manage 14 vents instead of 10. Or 20 instead of 12. It makes no sense. And it's not safe and it's not good practice. I'd love to hear your thoughts, your responses, and most importantly, I hope you have a great day.